Now are you able to hear me? Okay, fine. Okay. Okay, great. So rubber band extraction is a method of extraction in patients having, yeah, correct, bleeding disorders. Okay, that was used previously, not now. So the red line in Winter's classification of impacted teeth represents, what is red line? Yeah, correct. The depth at which the impacted teeth is located. Okay, see here is the white line, that is the occlusal level. The amber line, that is the alveolar bone height, and the red line is the indicator of the depth of which the third molar is situated. Okay. So difficulty score for a mesioangularly impacted third molar, class 2 and position B is, this is the Peterson's difficulty index. Yeah, it is 5. Okay, this is the Peterson's difficulty index. It is according to the spatial relationship. If it is mesioangular 1, horizontal 2, vertical 3, distal angular 4, depth ABC is 1, 2, 3, and Ramus relationship class 1, 2, 3 is 1, 2, 3. So difficulty index, if it is very difficult, then 7 to 10, moderately difficult 5 to 6, and slightly difficult is 3 to 4. Howe and Poynton in 1960 developed a criteria to diagnose the C. Relationship of the root epiphysis to the impacted third molars to the inferior alveolar canal. So how do they describe it? They describe the relationship between the root epiphysis and the inferior alveolar nerve canal. That is related but not involving the canal. If it is in a close proximity, related to changes in the root, that is the darkening of root or dark and bifid root, narrowing of the root, or overlapping if the canal is deviated or if the canal has a hourglass shape. According to Killy and Kay, all the following are absolute indications for removal of tooth from fracture line except correct. D. Okay, the tooth is which is intact but present in the line of fracture and shows no evidence of mobility or inflammation. So if there is a tooth which has no mobility or not infected or not fractured, then we may keep the tooth in place for the fracture and just put a plate over that tooth itself. We will not remove the tooth. But if the tooth is fractured, then we will remove the tooth and then plate the fracture. A 32-year-old female patient underwent an extraction of her upper first molar on the right side, and 0.3 mm of perforation was created in the sinus wall. What procedure do you like to carry out? Yeah, correct. So if the perforation of the sinus wall is only 0.3 mm, that is, if it is 1 to 2 mm, we don't need any treatment. If it is more than that, we will put a suture or use a flap. The anterior releasing incision in modified Watt's flap design for mandibular wisdom molar is placed. Okay. It is mesial to second molar. Actually, it is placed on the distobuchal line angle of the first molar. But here the option is changed as mesial to second molar. You understand, no? See, actually it is placed on the distobuchal line angle of the first molar and the extends through the second molar and the distal release incision. Okay, this is modified Watt's. Distobuchal line angle of first molar is the anterior release incision, clavicular incision through the second molar, and distal release incision here distally over the alveolar ridge. This is used for completely impacted third molars. This is a regular Watt's incision. Okay, we place the vertical release incision in the distobuchal line angle of the 7 and curve it anteriorly, and the length is 6.4 mm. Okay, we put a clavicular incision and a distal release incision, not from the middle of the 8, but from the distobuchal line angle of 8. It should be here. Okay, in this diagram it is wrong. It should be here, and the total length is only 2 to 3 mm. Okay, because sometimes you will have the lingual nerve exactly on the crest of the alveolar ridge. In 7 to 10%, the lingual nerve lies exactly on the crest of the alveolar ridge. So with this, we complete the exodontia. Now we move on to local and general anesthesia. Of course, this is a very favorite and familiar diagram to all of you. This is the pterygomandibular raphe. It is a buccopharyngeal fascia which attaches from the medial pterygoid plate to the retromolar region. And this is the coronoid notch. This is the injection site. You inject 6 to 10 mm above the occlusal plane. Okay, this is for the inferior alveolar nerve block. This is the endotracheal tubes. Okay. This is a endotracheal tubes. This is a nasal cuff north pole. This is a plain south pole tube, and this is a why we need to know about endotracheal tubes is for general anesthesia. In general anesthesia, they give something called as the inducing agent and maintenance agents. That is a injection which is given for the patient to anesthetize the patient. Okay. When they anesthetize the patient, they also give muscle relaxants. What does the muscle relaxants do? They relax all the muscles, including the respiratory muscles and the lungs, except cardiac muscle. Cardiac muscle, it will beat on its own. It is autonomic. Okay. But the lung muscles and the lungs, they will collapse. So we have to do something called as the ventilation. We have to ventilate the patient. In order to do that, we have to intubate the patient. The process is called intubation. We need to put a tube from the mouth to the trachea or to the nose to the trachea. We use something called as a laryngoscope. This instrument is called laryngoscope. We lift the tongue. See here, we lift the tongue, lift the epiglottis, see through the vocal cords, and put the endotracheal tube into the trachea. Okay. This is something called as the submental intubation. When there is a severe panfacial fracture, all the bones in the middle third are fractured, even the mandible is fractured, then we convert, we first put a orotracheal intubation and then we convert into submental. We take the tube out through the floor of the mouth in the chin region. This is called submental intubation. This is called a retromolar intubation. If we are not able to get it through the nose, then we put it through orally and place the tube behind the last molar. So till now we have discussed we are using a laryngoscope when the patient is able to open the mouth. What if the patient has severe trismus? Then we use something called as the fiber optic endoscope. This has a camera in it. Okay, this is a fiber optic endoscope, and the surgeon can, anesthetist can see through this and see the vocal cords and the trachea and put the endotracheal tube through the fiber optic endoscope. So moving on to the questions, which of the following local anesthetic agent would be preferred in prolonged surgical procedures? Yeah, the answer is bupivacaine. Okay. So classification according to the duration of action: short duration, intermediate duration, and long duration. Short duration is 30 minutes. Intermediate duration is 60 minutes. That is lignocaine with adrenaline is intermediate duration. That is what we regularly use. Okay. So which of the following is the preferred local anesthetic technique for hemophilics? Yes, correct. It is intraligamentary. Okay. Why intraligamentary? Because that has the least amount of bleeding. Okay. Others have a risk of bleeding. If you give a nerve block or a field block, then you risk bleeding in hemophilics. Okay. So we have to use intraligamentary. In anesthetizing lower anterior teeth, all of the following are indicated except lower anterior teeth. Sorry, that word is missing. It should be lower anterior teeth. Yes, correct. You cannot use mental nerve block because mental nerve supplies only the soft tissue. It does not supply any teeth. Okay. Lower anteriors are supplied by incisive nerve, not mental nerve. Which of the following muscles is pierced by the needle while giving an inferior alveolar nerve block? Of course, this is a very common question. Yeah, it is. No, not buccinator. Not buccinator. It is medial pterygoid. Okay, it is medial pterygoid. I'll tell you. See, we give inferior alveolar nerve block in the pterygomandibular space. Okay, pterygomandibular space is this space which has the mandible, the medial aspect of ramus of the mandible laterally, and the medial pterygoid. And the medial pterygoid medially. So we pierce that muscle only when we are giving inferior alveolar nerve block. Okay, it is medial pterygoid. Of course, we'll be seeing this pterygomandibular space a lot of times, so you can revise that. The bilateral mandibular nerve block or inferior alveolar nerve block. Can we give bilateral inferior alveolar nerve block? Yes, the correct answer is it is not contraindicated. Why? If they say that it is dangerous because there might be tongue fall, we anesthetize only the lingual nerve. Lingual nerve supplies only normal sensation to the anterior two-thirds of the tongue. It has nothing to do with the muscle movement. Motor supply is by the hypoglossal nerve, and more actually the posterior most part of the tongue is supplied by vagus nerve. So we will not anesthetize any motor muscles to cause tongue fallback. We will only anesthetize the normal sensation in the anterior two-thirds. So patient might having difficulty in talking for the 2 hours. There will not be any tongue fall. It is not contraindicated. You can always give bilateral inferior alveolar nerve block or mandibular nerve block. Yeah, let's see. Which of the following general anesthetic technique should be used for anesthesia in oral and maxillofacial surgery? Yes, correct. Nasoendotracheal tube with a throat pack. Throat pack is a must. That is a piece of gauze is inserted into the throat around the endotracheal tube to prevent any, tooth material or bone entering into the trachea. LA with adrenaline is absolutely contraindicated in. This is a direct question. Yes, hyperthyroidism, because there is chances of thyrotoxicosis. Okay. In systemic LA toxicity, there is, yes, correct, B. It is post-convulsion depression. Okay. See here, this is from Malamed, this diagram. First, there is tonic-clonic seizures, then it finally leads to CNS depression. So there is post-convulsion depression. Okay, that is the answer. Which of the following local anesthetics will be suitable for a hypertensive patient suffering from a heart disease? Yeah, I thought so. Most practitioners will think it is lignocaine without adrenaline because that is what we've been giving, no? But theoretically, it is prilocaine and felipressin. Okay, theoretically, it is prilocaine and felipressin because felipressin has a minimum cardiovascular stimulatory action and non-dysrhythmogenic. Okay, felipressin is a catecholamine vasoconstrictor that is chemically related to vasopressin. So the answer is prilocaine with felipressin. Okay, theoretically. Practically, of course, we all use lignocaine without adrenaline. Okay. So when blocking a nerve containing both sensory and motor fibers, the lost functional property lost is, yeah, correct, proprioception. Okay. So the loss of function will be in this order: pain, temperature, touch, proprioception, and skeletal muscle tone. The return of the sensation is in the reverse order. Okay. So each of the following statements about local anesthesia is correct except lignocaine causes cardiac dysrhythmias. Prilocaine is more toxic than lignocaine. Prilocaine and lignocaine are components of EMLA. Bupivacaine is given for obstetric epidural anesthesia. Here, there are two keywords. Each of the following statements about local anesthesia is correct except. That means you have to find the statement which is false. Okay, you have to find the statement which is false. That is, prilocaine is more toxic than lignocaine. That is the false statement. Answer is B. Prilocaine is more toxic than lignocaine. Prilocaine is less toxic than lignocaine. We just saw, no, in hypertensive patient, prilocaine is used. So prilocaine is less toxic than lignocaine. Of course, there is a common toxicity of prilocaine, that is methemoglobinemia, but still it is less toxic than lignocaine. Which of the following can be used as a local anesthetic agent for infiltration if a patient is allergic to amide and ester derivatives? Yes, correct. Diphenhydramine. Diphenhydramine is an antihistamine that can be used as a local anesthetic agent if the patient is allergic to both ester and amide anesthetics. Okay, this was a very old article written by the great Stanley F. Malamed himself. Use of diphenhydramine in is a local anesthetic agent. Okay. So the dose of epinephrine given in anaphylaxis is yes 0.5 milligrams 1 in 1000 IM. Okay. If you are using IM, we can use 1 in 1000 0.5 mg. If you are using diluted IV, then it is 0.5 milligrams 1 in 10,000. So IM is 1 in 1000 and IV is 1 in 10,000. 0.5 is same. Okay. LA acts on the nerve membrane by, of course, this is a direct question. See, long answers will always confuse you. Okay. So first what you have to do is LA acts on the nerve membrane by, don't see the choices. You have to first recall in your memory what is the mechanism of action of local anesthesia. It blocks the sodium from entering from the exterior to the interior. So B is the answer, blocking conductance of sodium from exterior to the interior. You have to look for the answers which you already know. If you read all the options, then you will get confused. Okay. The action of long-acting muscle relaxants using general anesthesia may be terminated by. This is called, something called as a reversal agent in general anesthesia. Yeah, neostigmine. Okay, that is the reversal agent for general anesthetic agents. Ketamine is a dissociative anesthetic agent. Succinylcholine is a muscle relaxant, and atropine is a pre-anesthetic medication. Okay, neostigmine inhibits the hydrolysis of acetylcholine by competing with the acetylcholine for attachment to acetylcholinesterase at sites of cholinergic transmission. Allergic reaction in patients who receive amide type of local anesthetics for dental procedures are most likely caused by the reaction of exactly. Most people might think lignocaine is the agent which causes the allergic reaction, but it is not true. It is methylparaben which causes the allergic reactions. So if you see the lignocaine which is used for cardiac arrhythmias, they will not have any preservatives. Okay, it will be plain lignocaine. So it is methylparaben which causes the allergic reactions. Sometimes sodium metabisulfite also could causes allergies. Yes, coming to the same question. Inferior alveolar nerve block is given in which space? Correct. It is pterygomandibular space. Okay. So see here, pterygomandibular space, the boundaries are superiorly, it is the lateral pterygoid muscle. Laterally, it is the medial surface of the ramus. And medially, it is the medial pterygoid muscle. Posteriorly, it is the parotid gland. Anteriorly, it is the pterygomandibular raphe. Okay, the contents are inferior alveolar neurovascular bundle, lingual and auriculotemporal nerves, mylohyoid nerve, and vessels. Okay, so it is the space between the ramus and the medial pterygoid muscle. Superiorly, it is lateral pterygoid, posteriorly parotid, and anteriorly pterygomandibular raphe. Color of nitrous oxide cylinder. Yes, it is blue. Okay. So oxygen is white. That is the neck of the cylinder. They will paint in white. Nitrous oxide, it is blue. Medical air, black and white. Carbon dioxide is gray. The earliest sign of syncope is, yes, pallor. Okay. Sudden appearance of dumbbell shaped swelling during third molar nerve block is mainly due to, okay, I can see multiple responses here. Initially, we used to think that the hematoma, which is caused by the upper third molar block, that is the posterior superior nerve block, is due to the injection in the pterygoid plexus of veins. Okay, but recently it is changed. It is injection into the internal maxillary artery. See, it was believed for a long time the answer was pterygoid plexus. Okay, but Scheiser and Dubrul in 1975 they suggested that it is because of the posterior superior alveolar artery, which is branch of internal maxillary artery, that is the source of the hematoma. Okay, so it is internal maxillary artery. The answer is C. Maximum concentration of, sorry, answer is already there. Lignocaine for topical anesthesia is 15%. That is in the spray. Okay, ointment is 2% or 5%. What is EMLA? Yes, answer is A. It is a mixture of 24 milligrams per kg lidocaine plus 24 milligrams of prilocaine. That is the eutectic mixture of local anesthesia used for skin. You must have seen the patches in the kids. They are admitted into the hospital before putting the vein access. They'll put a patch over the kids like this. That is for the skin to get anesthetized. That contains a prilocaine ointment. The gas used in LA cartridges, yes, it is nitrogen. Why? A small bubble of approximately 1 to 2 mm diameter is frequently found in the dental cartridge. It is composed of nitrogen gas to prevent oxygen by being trapped in the cartridge and potentially destroying the vasopressor. In CPR, the sternum should be depressed at a rate of it is 2 inches per 1 second. Okay. The heart is situated at the depth of 2 inches from the ribs. So you have to compress 2 inches at least to compress the heart and maintain the circulation. Okay. Fibers which transmit pain from the pulp are A delta and C fibers. Okay. Which among the following should be the last resort for giving LA technique to the patient? Yes, it is intrapulpal. That should be the last resort. After you have tried everything, then you should access the intrapulpal. Local anesthetic with the lowest placental transfer is it is chlorprocaine. Esters have lower penetration than the amides. Patient who had a history of hepatitis 1 month ago should preferably given which local anesthetic agent? Yeah, procaine. Okay. Procaine is metabolized by the blood plasma cholinesterase. Unlike the amides, which are biotransformation undergoes in the liver by the microsomal enzymes. Okay, with this we complete the LA and GA. Next, we move on to mandible fractures. So this is according to Digman and Natwig. Okay. According to the anatomical region, condyle, coronoid, ramus, angle, body, parasymphysis and symphysis. Okay. This is according to the trajectories of the mandible. The forces are transmitted in these directions. This is a gunning splint which we use to fix the mandibular fractures in edentulous patients. Okay. 7-year-old boy presented with fracture of left subcondylar region with occlusion undisturbed. Every question will have keywords. So here the keywords is 7-year-old. Yeah, correct. Here the keyword is 7-year-old and occlusion undisturbed. So the answer is no immobilization and active mouth opening. Okay, no immobilization. You no need to immobilize the kid. If the occlusion is undisturbed, then there is no need to treat. You just have to advise soft diet and active mouth opening exercise, especially if it is 7-year-olds. A fracture mandible should be immobilized for an average of answer is B. 6 weeks. 6 weeks is the usual immobilization period for a fracture mandible. Okay. Bucket handle type of fracture are seen in. Yes, correct. Edentulous people. Okay. We'll see why. See, if the edentulous patients are there, the mandible is severely atrophied. So, because of the muscle pull, the myloid and the digastric muscle pull, the mandible fractures at the body like this. This is called as a bucket handle fracture. The treatment for a mandibular fracture between the incisors is okay. Okay, I can see many responses. The answer is resistance wiring. If the fracture is in between the incisors, we use a resistance wiring. I'll explain each of the wirings. Okay, first you place a wire from the molar to molar. Then you pass a wire from here till here like this, and then go lingually, and then go here and tie it. And then you secure that wire individually by placing interdental wires. This is called residence wiring. The S6 wire, you place a wire 3 teeth away from the fracture line like this, buccal, lingual, buccal, lingual, buccal, lingual, and you pass the wires around the buccal lingual region of fracture line, and the opposite side also you have to pass through buccal lingual wires of 3 teeth, and then you secure that wire around the fracture line by passing interdental wires separately. This is S6. This is circummandibular wiring. This is used in treatment of pediatric mandible fractures. Okay, because of the permanent tooth buds, we cannot open and put a plate. So what we do is we fabricate a acrylic splint over the existing mixed dentition or the deciduous teeth and secure it with the wires and a groove in the acrylic splint. So open reduction and fixation of fractured mandible condyles is indicated when? Yes, correct. It is shortening of the ramal height is more than 5 mm according to Zaid and Kent criteria. Okay, there is a criteria called Zaid and Kent criteria, which is for open reduction of condyle fractures. Open reduction is you take the patient to GA, open the condyle through a preauricular incision or a submandibular incision, open it and fix. That is called open reduction and internal fixation, ORIF. So absolute indication and relative indications. So direct interdental wiring is also known as Gilmer's wiring. Okay, direct interdental wiring is also known as Gilmer's wiring. So we already saw S6 wiring. This is Gilmer's wiring. You place wires around the tooth and tie it from the maxilla and the mandible. That is Gilmer's wiring or direct interdental wiring. This is resistance wire. You pass a single wire from molar to molar and secure the individual teeth with interdental wires. This is IV's eyelet wiring. You form a, okay, start here. You form a eyelet, insert both the wires interdentally and take it out on the adjacent tooth and pass a single wire from the distal to mesial and then tie it. This eyelet is used in the intermaxillary fixation. You tie the eyelet in maxilla and mandible. This is IV's eyelet. This is coronal stouts. You place a plastic tube and loop around the teeth. An adult patient sustained a subcondylar fracture on the left side. Clinically, it is seen that there is so I'll tell you the concept behind this. There is a subcondylar fracture on the left side. So what will happen? The mandible will always deviate to the affected side. Yes, correct. So inability to deviate the mandible to the right. Okay, because that is the deviation of mandible to the right is the action of the left lateral pterygoid muscle. Okay. Can you see this? So here is the lateral pterygoid plate. Here is the condyle. So this lateral pterygoid, when it pulls, it deviates the mandible to the opposite side. Okay. So what happens? If there is a subcondyle fracture on the left side, the condyle will move on to the left side only. Patient cannot deviate to the right. Okay. See here, this is the medial pterygoid and this is the lateral pterygoid. If this contracts, the mandible deviates to the opposite side. So if there is a subcondylar fracture here, so this will not act. So when the patient opens the mouth, there will be deviation to the affected side wherever there is fracture, because the opposite side lateral pterygoid will be acting normally. The extraoral X-ray view required for a fracture of mandible is it's a simple posterior anterior view. Okay. Yeah, posterior anterior view. PA view of skull. That is the extraoral X-ray. Post-auricular ecchymosis in cases of fracture of the base of skull is called bad. Okay, what is Tinel's sign? It is a way to detect irritated nerves. It is performed by lightly tapping over the nerve to elicit a sensation of tingling or pins and needles in the distribution of the nerve. It takes the name from French neurologist Jules Tinel. Schwarzschild sign is described as the twitching of facial muscles in response to tapping over the area of facial nerve. Crusoe's sign is carpopedal spasm that results from ischemia, such as that induced by pressure applied to the upper arm from a inflated sphygmomanometer cuff in tetany. Nikolsky's, of course, you see that in pemphigus. Patient of 40 years, male, got a blow in the angle region of mandible and he is asymptomatic. The race that region shows a radiopaque line with a very sharp undercut in the lower border of the mandible, which may be due to, yes, correct, it is overlapping sign. Okay, you see here, because of the muscle pull, one segment of the mandible is overlapped onto the another segment. So there is a overlapping of mandibular segment which causes the overlapping sign and a thick radio opaque line. Yeah, okay. The radiographic view of choice for diagnosing horizontally favorable and unfavorable fracture is. Okay, let us see. Yes, yes. The answer is lateral oblique view. Let us see what is horizontally favorable and unfavorable and vertically favorable and unfavorable. When I used to, when I was studying UG, I never understood this concept. Why they are calling this as horizontally favorable and unfavorable and this as vertically favorable and unfavorable. It is from the viewing axis. Okay, you view this in a horizontal plane. Like this. Like this. This is in a horizontal plane. Okay. When you view it vertically, from top to below, like this, okay, from top to below, then it is called a vertically favorable or unfavorable. Favorable or unfavorable because of the fracture line extending and the muscle pull. If it is favorable, if the fracture line is extending from here to here, the pull of the masseter approximate the fractured fragments. That is favorable fracture. If the pull of the masseter and the medial pterygoid separates the fractured fragments away from one another, then it is called unfavorable fracture. Same here, okay? If it approximates the fracture, it is vertically favorable. If it separates the fracture, then it is vertically unfavorable. Okay. In fracture of the atrophic mandible with bone loss, which is the best treatment modality? Yes, it is load bearing. Okay, because it is a atrophic mandible. Because it is an atrophic mandible, we need a load bearing that bears the weight of the mandible. You see here, this is a load bearing thick plate. Okay, this is 2.5 mm thick plate. Okay, you see here, I'm sorry for the poor visibility. I'm not exactly knowing where to show. This is a thinner plate. This is all load sharing. This has to bear the load of the mandible. This is a thicker plate. Okay. So we need bone grafting with load bearing. See here, we need a thicker plate. Okay, so that it bears the load of the mandible, and it has to be to both the cortices, buccal and lingual cortices. See here, we tell name this as a reconstruction plate. This is an angle reconstruction plate, and this is a straight reconstruction plate. Okay. Transverse symphyseal fracture of mandible can be managed by all of the following except. Yes. No. It is 1.5 mm single mini plates. See here, 1.5 mm single mini plate is used in the maxilla like this. Okay, it is the thinnest plate available. We need at least 2 mm plates. That is like this here. 2 mm plate or 2.5 mm is the reconstruction plate, which I showed you earlier. This is a 2.5 mm plate, or we can use lag screw, but not 1.5 mm single plate. That cannot withstand the force of the mandible. Adult patient with a condyle fracture, occlusion is normal with normal mouth opening. The best treatment is. This is more or less similar like the first question we saw. 7-year-old adult. Yes. The answer is conservative treatment, close observation, soft diet, and return to normal function as soon as possible. Okay. In mandibular angle fracture, which is the most appropriate treatment?
I know, I don't want. Sure. No, I'll manage.
Yeah. It is one plate on the oblique ridge. Okay. See here. In the angle, we put one plate on the external oblique ridge. Okay. That is the most appropriate place to plate an angle fracture. Okay. This is according to the ideal line of osteosynthesis. So if it is symphysis fracture, we put 2 plates. If it is body or angle fracture, we put only 1 plate. Okay. That is because of the line of osteosynthesis. Use of acrylated arch bars for close reduction of mandible was described by
What?
Yeah, Schucard in 1966. Okay. In fracture of body of mandible, the mini plate is given between the upper and lower border. Okay. It is between the upper
Not
and lower
bad.
border.
If subjects have studied, I can answer. They will directly.
Then the model paper.
No, he's asking questions only. He's saying it's from the pulse book only. It's not you should have studied by now. He's explaining it.
So elephant foot deformity is indicator of yes, correct. It is non-union of fractured edentulous mandible. Okay. See here, if there is a fracture in the edentulous mandible and there is a non-union, then this becomes like an elephant's foot. So it is called elephant foot deformity. Simplifying fracture is done in yes, correct. This is a comminuted mandible fracture. Simplifying fracture is arranging and orienting the fractured fragments in order to provide an anatomical shape to the bone. See, for example, here there is a comminuted fracture of the mandible. The mandible is fractured in many places. So they have arranged it into the anatomical position. See here, it is so much displaced here, everywhere. It is fractured into multiple pieces. But they have arranged and reoriented and plated perfectly. This is a perfect reduction. In mandibular fracture with gonial flaring, the best location to do plating is yes, it is lower border plating. I said before the best location for an angle fracture is the external oblique ridge. But if there is a gonial flaring, then we have to do it extraorally with the lower border plating. What is the name of this method and what instrument is being used? I guess you will have a lot of picture based questions in NEET. Yes, it is A. Okay. So this is a circummandibular wiring with the help of William Kelsey Fry bone owl. What we do in pediatric mandibular fracture is we insert a bone owl from the inferior border lingually and we guide a wire through that, pull that wire through the lower border and insert it again through the buccal side. Okay, and fix a acrylic splint over it and tie it off. Okay, so this is circummandibular wiring with the William Kelsey Fry bone owl. This is the external skeletal fixation with the plaster of Paris skull cap. This is a hollow frame. We don't use all these anymore, just for theoretical purposes. This is a suspension wiring. This is transosseous wiring. Okay. Nowadays, mostly it is not used. We use only mini plates like this. Okay. This is a mini plate osteosynthesis. Yeah. This is called a dynamic compression plate, where if you tighten the screw, the fracture gap reduces. When you start tightening, the dynamic compression forces the fracture to close and there will be minimal space so that better healing. This is a regular fracture kit. Okay, we have a screw holding forceps, screwdriver, tweezers. These are the titanium mini plates, straight plate, L plate. This is a 3D plate. Okay, this is a bone reduction clamp. Okay, if the fracture is mobile, then we reduce and hold the fractured fragments with these bone reduction clamps. So we'll move on to middle third fractures. So these are the different soft tissue wounds in the orofacial region. Okay. So this is a subconjunctival ecchymosis. There is a ecchymosis in the conjunctiva. Okay. This is a fracture mandible with a hematoma. This is called Coleman sign. This is a force reduction test to check the entire range of ocular motion so that we will make sure that there is no muscle entrapment which will cause diplopia. This is done in orbital fractures. Okay, this is the reduction of maxillary fractures. This is the Rose maxillary disinfection forceps, and the 2 is the Hayden-Williams forceps. Which of the following is not included in the Glasgow Coma scale? Of course, a simple question. Yeah, pupil size. Okay. So this is the Glasgow Coma scale or GCS. Total score is 15. So it is based on the 3 responses: eye opening, verbal response, and motor movement. Okay. CSF rhinorrhea is found in, yes, it is from the nasoethmoidal fracture. Okay. If there is a fracture of the cribriform plate of the ethmoid, then there is leak of the CSF from the brain to the nose. So patient will have CSF rhinorrhea. 35-year-old man with Leaford 3 fracture complains of blood-tinged watery discharge from his nose 3 days after the trauma. CT scan confirms NOE fracture as well. What investigation is most confirmatory for detecting CSF leak? Yes, it is presence of transferrin beta. Okay, beta 2 transferrin is a carbohydrate free isolated form of transferrin which is almost exclusively found in the CSF. It is not found in blood, mucus, or tears, thus making it a specific marker for cerebrospinal fluid. Okay, so the answer is transferrin beta. After fracture of the middle cranial foramen, there is epiphora. This is due to damage of okay. Let us see what is epiphora. Okay, epiphora is the excessive tears that is yes, correct. The answer is D. Okay, epiphora is an overflow of tears into the face. That is because of the complete or partial obstruction to the nasolacrimal duct. Nasolacrimal duct drains in the nose near the middle meatus through valve of Hasner. Okay, if it is obstructed, then there is epiphora. There is excessive tears. Okay, what we will do something called as a DCR, dacrocystorhinostomy, to correct that epiphora. Okay, so answer is none of the above. Here is the catch: if none of the above is given, don't think that might not be an answer. It might also be an answer. Okay, so you have to consider that also into option. Which of the following is not a feature of Leaford 2 fracture? Yes, answer is A, anophthalmos. Okay. Leaford 2 is a pyramidal fracture which involves the maxilla and the nasal bones, the infraorbital region. Okay, so these are the clinical features of Leaford 2 fractures: ballooning or moon face, reduction of step deformity, mobility of the maxilla. Okay, but no anophthalmos. Forceps used for maxillary fracture disimpaction. Yes, Rose maxillary disimpaction forceps. This is the Rose maxillary disimpaction forceps. It is a paired instrument used to mobilize the maxilla. Okay. This is a Bristow's elevator used in zygomatic arch fractures. Okay. This is a Rose modification of Bristow's elevator, which is used in Gillies temporal approach. Advantages of this handle is you can see where the tip of the instrument is and you don't fracture the temporal bone. If you use Bristow's elevator, you will fracture the temporal bone. There are chances of fracture of the temporal bone. Walsham's forceps is used to reduce the nasal bone fracture, lateral nasal bone fractures. Ash's forceps is used to reduce the septum, nasal septum. Diplopia is most common with, yes, zygomatico-maxillary complex fracture, because there is a fracture of the infraorbital ridge and there is chances of muscle entrapment, especially inferior rectus. The hanging drop appearance in the maxillary sinus radiograph indicates, yeah, blowout fracture of the orbit. So here is this is a CT scan. Here is the contents of the orbit into the maxillary sinus. So this is a blowout fracture. The infraorbital floor gets fractured when there is a severe trauma from the outside and the contents of the orbit enters into the maxillary sinus. This is called a blowout fracture. This is a blow-in fracture. If the contents of the superior orbital ridge enters into the orbit, then we call it as a blow-in fracture, which is the immediate danger to a patient with severe facial injuries. Exactly. It is a respiratory obstruction. Okay. If there is a bilateral parasymphysis fracture, then there are chances of the tongue falling back and causing a respiratory obstruction, or if there is a maxillary fracture, there will be a lot of bleeding and obstructing the airway. So the immediate danger with severe facial injuries is respiratory obstruction. You have to clear the airway first. In depressed zygomatic arch fracture, the difficulty in opening the mouth is caused by the impingement of, yes, exactly, coronoid process. Okay. See here, there is the fracture of the zygomatic arch and it goes and impinges into the coronoid so that the mouth opening is restricted. This is Gillies temporal approach to reduce the zygomatic arch fracture. You insert an elevator and elevate the zygomatic arch. This is a intraoral approach. It is called Keen's approach. Easier intraoral Keen's approach to reduce the zygomatic arch fractures. There are two approaches. This is an extraoral approach called Gillies temporal approach, and this is a Keen's approach, which is intraoral. True open bite is caused by, yes, horizontal fracture of the maxilla. Because what happens in a horizontal fracture, of course, this is a panfacial fracture, but just see the maxillary part. The horizontal fracture of the maxilla, that is a Lefort 1 fracture, causes the maxilla to gag in the posterior region. That is the molars contact first, and there will be an anterior open bite. In Lefort 3 fracture, all are seen except, yes, correct. This is one of those questions where the answer is none of the above. So in Lefort fracture, everything is here. Crackpot sound, CSF rhinorrhea, fracture of the frontozygomatic suture, the whole face is mobile because it's a craniofacial disjunction. This is a Lefort 3 fracture. These are the clinical features. Panda facies, disc face deformity, battle sign, okay, anti-mongoloid stand, everything is seen. The muscle that aids in the displacement of maxillary fractures are, yes, correct. It is none of the above because only in mandible fractures there is a displacement because of the muscles. In maxillary fracture, none of the muscle helps in displacing the maxillary fracture. Okay. Incision given within the hairline 45 degrees to zygoma is, yes, correct, Gillies temporal approach. Okay. This is the Gillies temporal approach, incision between the superficial temporal artery, two branches, 2 centimeter in the hairline, superior and anterior to the helix. Okay. This is the Alkayat-Bramley incision. This is a preauricular incision extended in the form of a question mark. This is used in treatment of TMJ ankylosis. Residence incision is a submandibular incision used to approach the angle or the condyle. Morris is a transurethral incision. I'm explaining about the other options in that question. The intercanthal distance suggestive of traumatic telecanthus is, yes, correct. It is 40 mm. Okay. So traumatic telecanthus is because of the naso-orbital ethmoid fractures that has a traumatic telecanthus. Telecanthus is the distance between the medial canthus of the left and right eyes. Okay. If it is more than 40 mm, then there is a traumatic telecanthus. Latent period of distraction osteogenesis in 8 months old child. Yes, answer is A. Okay. Usually it is 5 to 7 days in adults, but if it is a 8-month-old kid, it is 0 to 2 days because of the faster bone metabolism. Which of the following enzymes can be detected in CSF? Yeah, I can see multiple responses. The answer is LDH and CK. Okay, CKMB is detected in a cardiac event. Okay, lactate dehydrogenase is 10% of serum level. It is increased in cerebrovascular accidents, CNS tumors, and meningitis. Creatinine kinase are associated with the neurological injury in global anoxic brain insults due to respiratory or cardiac arrest. CK BB levels 24 to 72 hours after injury can be used to estimate the overall extent of brain injury. So CKMB is in the elevated in cardiac arrest. Okay. Anti-mongoloid stent is a feature of, yeah, D. Leafort3, we already saw this. This is a anti-mongoloid slant. This is not a Leafort3 fracture, but I want to show you the anti-mongoloid slant. So we'll move on to cyst and tumors. So needle aspiration of a central bone lesion is useful. Yes, to rule out a vascular lesion. If you aspirate, if you get blood, it's a vascular lesion like this. So it is a central hemangioma. Do not do anything to this patient, just refer to a higher center. Which of the following surgery is indicated for the removal of 3 centimeter ameloblastoma involving the inferior border of the mandible? Yes, the answer is resection. If it is a tumor, you cannot enucleate or do anything else. It has to be resected, especially when it is involving the inferior border of the mandible. See here, there's a huge ameloblastoma involving the inferior border of the mandible. So the entire mandible is resected on the side, okay, including the condyles. 14-year-old boy has delayed eruption of the second molar. Radiography shows a dentigerous cyst surrounding the crown of the tooth. The treatment of choice. Yeah, expose the crown and keep it exposed. That is called marsupialization. So what you do is you create a window of opening in the cyst and suture that lining to the adjacent mucosa so that the cyst degranulates and it reduces in size and allows the tooth to erupt. So this is marsupialization. Treatment of fibrous dysplasia. Yeah, if the lesion is small, the dissection is done. If the lesion is large, cosmetic surgery has to be carried out. See, there is a huge fibrous dysplasia of the maxilla on the right side, and cosmetic reduction is done for this patient. Okay. Man has 1 to 1.5 centimeter pedunculated lesion on the soft palate, which has a rough warty surface, but it's the same color as the adjacent mucosa. Appropriate management of this lesion is to perform excisional biopsy. This is a benign wart. We can remove it. Okay, it is caused by the human papilloma virus. When treated with simple curettage, which odontogenic tumor is most likely to recur, which has the highest recurrence rate? Yeah, odontogenic myxoma, that has a 33% recurrence rate, more than the ameloblasttic fibroma. Okay. This is a odontogenic myxoma of the right mandible in a 10-year-old male patient. Okay. What is the treatment of ameloblastoma? Yeah, I can see multiple responses. The correct answer is resection of mandible along with the tumor. Okay, it is not just the excision of the tumor. We have to resect the mandible along with the tumor. Mandible has to be removed. I showed you in the earlier slides. No, you have to remove the mandible with the inferior border. Biopsy specimens removed from examination are immediately placed in, yes, 10% formally. Okay. Submandibular calculus can be removed by incision of the duct and the removal of calculus. You put an incision in the duct and remove the calculus. Okay. Of course, if it is a small calculus, we can do it by milking of the duct. And if the submandibular gland calculi is located in the gland, you have to remove the gland itself. But in these given options, this is the best one. Okay. During surgical excision of the parotid gland, the following structures may be damaged. Which are the important anatomical? Yeah, correct. Okay. Facial nerve and auriculotemporal nerve. Of course, we all know facial nerve and the auriculotemporal nerve are situated in the parotid gland. Okay. See here, facial nerve branches inside the parotid gland itself. Salivary calculus is more common in, of course, we all know the answer. Yeah, because of the increased tortuous course of the submandibular gland duct and it has to flow against the gravity. This is a submandibular salivary gland calculi. Okay. Treatment of solitary Langerhans histiocytoma. Yeah, I can see multiple responses. Answer is curettage. Okay. Langerhans cells are dendritic cells of the skin and contain organelles called Birbeck granules. Langerhans cells histiocytosis is a group of idiopathic disorders characterized by the proliferation of specialized bone marrow derived Langerhans cells and mature eosinophils. Treatment of mucocele on the lower lip. Yeah, excision of the mucocele along with the adjacent glands, adjacent minor salivary gland. That is very important. You should not only excise it, you should excise it with the minor salivary glands also. Okay. Apical cyst having a direct connection with the apical foramen has been termed as? Yeah, it is base cyst or pocket cyst. It is a class of periapical radicular inflammatory cyst containing a sac-like epithelium lined cavity that is open and continuous with the root canal. Okay, this is called as a base cyst. Originally designated as a base cyst, contains epithelial lined cavity which is open towards the root canal of the affected tooth, initiated by the accumulation of neutrophils around the apical foramen in response to the bacterial presence in apical root canal. Okay. Of course, again a straight question. Carnage solution is used in the treatment of odontogenic keratocyst. Carnage solution is composed of chloroform, absolute alcohol, glacial acetic acid, and ferric chloride. Okay, it is used in a chemical cauterization. Okay, it removes the daughter cyst or the satellite cyst. En bloc resection of the segment of bone is done in it is the entire tumor is removed intact with the rim of uninvolved bone while maintaining the continuity of the jaw. That is called en bloc resection. You see here, we leave the inferior border. We remove the tumor along with some normal bone with the inferior border intact. This is called marginal mandibulectomy or en bloc resection. Segmental resection is we remove the mandible along with the inferior border. The entire mandible of that segment is removed. Okay, that is called segmental resection. During the surgery of the submandibular gland, okay, I can see multiple responses. The answer is B. Submandibular gland is seen to wrap around the posterior border of the mylohyoid. Okay. This is the explanation. The facial artery and vein do not course through the deep part of the gland. They are related to the superficial part. Okay. Option D, the nerve which lies in close relationship with the submandibular duct is the lingual nerve, not hypoglossal nerve. Damage to the lingual nerve will cause loss of sensation of anterior 2/3. Okay. Surgery is all about anatomy. You have to be very thorough with the anatomy. Following gland is removed in a surgery of a ranula. Yeah, it's a pretty direct question. Sublingual gland. This is a ranula. When you remove the ranula, you have to remove the sublingual gland also because it arises from the sublingual gland. Okay. What is Brown's tumor? Yeah, it is because of the parathyroid hormone. So you have to remove the parathyroid gland. You have to remove the tumor along with the removal of parathyroid gland. Okay. Which of the following is not a sclerosing agent? Yeah, this is pretty straightforward. So these are the sclerosing agents. Sclerosing agent are used in the reducing the blood flow of a vascular tumor. If it is a AVM, arteriovenous malformation or a hemangioma, you inject sclerosing agent, that is sodium tetradecyl sulfate, into the feeding vessel so that it scleroses the feeding vessel artery, and then we can operate later, that is within 72 hours. Which cyst is associated with complex odontoma? You can see various responses. It is Garland cyst, okay, or calcifying epithelial odontogenic cyst. This is a Garland cyst. Okay, it is calcifying epithelial odontogenic cyst. Why is the cyst lining radio opaque? Wow, very good, very good. It is the peripheral eggshell effect. Okay, peripheral eggshell effect. What is peripheral axial effect? The projection images, those that project three-dimensional volume into a two-dimensional receptor, may produce the peripheral axial effect. That is, the top photon has a tangential path through the apex of the egg and much longer path through the shell of the egg than does the lower photon, which strikes the egg at right angles to the surface and travels through two thickness of the shell. Okay. Treatment for aneurysmal bone cysts include. Okay, the answer is already there. It is all of the above. You can do all the treatments for a aneurysmal bone cyst. Aneurysmal bone cyst is a aneurysm is a collection of blood vessels. Okay, there will be a huge bleeding, so you have to be very careful when you are removing the aneurysmal bone cyst. Okay, see here, there is the angiogram shows a lot of blood supply, blood vessels through the tumor. This is a Weber-Ferguson incision for maxillary tumors. Radiographic features of pin box tumor. What is pin box tumor? It is CEOT. Calcifying epithelial odontogenic tumor. Answer is both of the above. Okay. So it has both honeycomb appearance and driven snow appearance. Okay. What is PTCH gene is suppressed by? Okay, the answer is KCOT. Yeah. It is keratocystic odontogenic tumor. Okay. So these are the different types of aspirates for different cysts. If it is clear, pale, straw-colored fluid, it is dentigerous. If it is creamy white, then it is a odontogenic cyst. If it contains lot of cheesy white material, then it is a OKC. Okay. Blood, if it is a vascular, is seen. Ecam striae is seen in, of course, the answer is already there, lichen planus. Greenspan syndrome, it is essential hypertension, diabetes mellitus, and oral lichen planus. So we'll move on to pre-prosthetic, orthodontic, and miscellaneous. Okay. So treatment of choice for a patient with a maxillary complete denture with severe bilateral tuberosity undercuts. Of course, it is a straightforward question. Yeah, you have to remove the tissue on only one side if possible. Okay, the other side we will use it for retention. This is the maxillary tuberosity soft tissue reduction. Bimaxillary protrusion may be surgically corrected by yes, correct. Removal of 4 premolars and anterior alveolar segment repositioning. So this is a case of bimaxillary protrusion. You see here her maxilla and mandible both are proclined. So this is after surgery. What we do, we extract the premolars, both the premolars, and we do something called as the AMO, anterior maxillary osteotomy. We cut through the anterior maxilla and position it back. This is for the maxilla. For the mandible, we extract the first premolar and we do something called as the subapical osteotomy. Okay, we push the mandible back. To obtain best long-term results, which of the following procedures for augmentation genioplasty is recommended? Yeah, pedicled horizontal sliding osteotomy. Okay, what is pedicled horizontal sliding osteotomy? You see here This is the right side and this is the left side. This is a facial midline. What you do is you cut the horizontal, you do a horizontal osteotomy, you flip the sides, you rotate it, and you keep a pedicle. Okay, you keep a pedicle for the genioglossus and the genioid. Here it is the muscle attachment. You keep the pedicle, you rotate it, flip it, and place it. See, this is the result. See here, horizontal flipping osteotomy. Myoplasty and sulcus extension procedures are helpful in increasing both retention and stability. Okay. The position that is least likely possible by means of a bilateral sagittal split osteotomy. Bilateral sagittal split osteotomy is a orthognathic surgery. Yes, correct. You cannot adjust it transversely. You can advance, you can set back, you can rotate the mandible, but you cannot move the mandible in transverse direction in a BSSO. So this is a BSSO. Okay. You split the mandibular ramus in half and you can advance or set back or you rotate, but you cannot move the mandible transversely in BSSO. During removal of a torus palatinus, it was noticed that the portion of the palatal bone is fractured. One would expect, opening into the nasal cavity. See here, oronasal fistula will be there. A patient is on periodic renal dialysis. Minor oral surgery should be performed. Yes, correct. 1 day after dialysis, because the heparin that is used during dialysis should wear off. The blood product of choice for treatment of hemophilics is B, cryoprecipitate. Okay, not fresh frozen plasma. Cryoprecipitate is prepared from plasma and contains fibrinogen, von Willebrand factor, factor 8, 13, and fibronectin. To create cryoprecipitate, fresh frozen plasma is thawed at 1 to 6 degrees and then centrifuged and the precipitate is collected. What is visor osteotomy? Yeah, excellent. It is a pre-prosthetic surgical procedure. Okay, it is a pre-prosthetic surgical procedure. What you do is, if there is a reduced height of the mandible, you split the mandible in the midline. Okay, like this. Okay, split the mandible in the midline into two portions and you raise one portion of the mandible and then fix it. This is called visor osteotomy. So we get to increase the height of the mandible to place dentures. Which of the following is used in the management of hemophilic patients? Yeah, tranexamic acid is a synthetic derivative of amino acid lysine that exerts its antifibrinolytic effect through the reversible blockade of lysine binding sites on plasminogen molecules. Intravenously administered is 10 milligrams per kg body weight and then infusion of 1 milligram per kg per hour. What is Abbe-Eslander flap? Excellent. Abbe-Eslander flap is used in the reconstruction of lip. See here, there is a defect in the lip. That is, if there is a basal cell carcinoma of the lip, then we have excised the lip, that particular portion of the lip. Then we use the lower lip, put an incision like this, and then rotate the lower lip to replace the upper lip, and then suture both. This is called Abbe-Eslander flap. Subcondylar osteotomy for the correction of prognathism was first reported by the answer is Robinson and Hinds. Okay, Obweiser was the person to perform the bilateral sagittal split osteotomy. IV diazepam causes the following in patient on dental chair. This is conscious sedation. If you give IV diazepam, yeah, varial sign or ptosis. The most frequently used signs for intravenous diazepam sedation is the ptosis, that is drooping of the upper lid, also known as the varial sign. Tinel sign we already saw, that is for the nerves, okay, irritated nerves. This is called battle sign. The Jorgensen technique on IV sedation for dental procedure drugs used are yeah, it is all of the above. Okay, Jorgensen technique of IV sedation uses all these drugs. It's accomplished by the incremental intravenous injection of pentobarbital, short-acting barbiturate, followed by the mixture of meperidine, that is pethidine, and scopolamine, that is used for treatment of motion sickness in a measured amount of sterile water or saline. The concept of one-stage full mouth disinfection has been put forth to prevent I think everybody has studied pulse very well. So this is to prevent translocation of microorganisms. Okay. Catgut suture is packed in it is packed in isopropyl alcohol, which acts as a preservative. Okay, just now I said sagittal split osteotomy was first advocated by excellent Obvigizer. Okay. First advocated, described by Trauner and Obgiser in 1953, and then later modified by Dalpont, Hansek, and Epker. The best graft for alveolar cleft surgery or the patient with cleft palate graft is taken from, this is for secondary alveolar grafting. I can see multiple responses. It is the anterior iliac crest. Okay, the anterior iliac crest is the most common site for obtaining the bone graft. The treatment for malignant hyperthermia is dantrolene. Okay. In patients with 15% blood loss, the immediate management is yes, excellent. Blood transfusion is not required. If it is 10 to 15%, does not cause significant drop in arterial pressure. If it is more than 25%, shock. In mass casualty cases, the mechanism to sort out patient is triaging. How will you triage patients? Yes, excellent. Treating patients with higher chances of survival with least available infrastructure. Campbell line is seen in the X-ray of following projection. Okay, I can see multiple responses. The answer is occipitomental. Campbell lines are imaginary lines traced across the face on an occipitomental or Waters view to assess for fractures. See here, the first line across the zygomaticofrontal, second line across the zygomatic-arch, third line across the condyles, fourth line across the mandible ramus, occlusal plane, fifth line is the Trapnell's line across the inferior border of the mandible from angle to angle. This is called Campbell and Trapnell lines. A 12-year-old child is HIV positive and comes to a dental clinic with severe pain due to abscess in the oral cavity and needs tooth extraction. What should be done? Yeah, excellent. You have any HIV positive patient who comes in, you should take the CD4 count and consult the physician. CD4 cells or white blood cells that fight for infection. The more you have, the better. So in HIV infection, these number drastically declines. When the CD4 count drops below 200, person is diagnosed with AIDS. And if the number is below 200, you should not do any procedures. Only if it is above 200, you can do extraction or fillings or whatever. Okay. The earliest operative procedure undertaken in the management of a complete unilateral cleft lip with alveolus and palatus. Yeah, excellent. It is chiliography. That is, you operate the cleft lip first. Okay, you operate the cleft lip first. That is the 6 months. At around 6 months, you do cleft lip. Then 12 to 18 months, you do palate, and then gingivoperiosteoplasty, primary alveolar grafting, and you do secondary alveolar grafting in 9 to 11 years for the eruption of the canine. Okay, then finally orthodontic surgery and rhinoplasty. Facial nerve lies. Yeah, correct. The answer is below SMAS and below the parotidomesenteric fascia. The superficial musculo-oponeurotic system, or SMAS, is often described as an organized fibrous network composed of the platysma muscle, parotic fascia, and fibromuscular layer covering the cheek. This system divides the deep and superficial adipose tissue of the face and has region-specific morphology. Anatomically, SMAS lies inferior to the zygomatic arch and superior to the muscular belly of the platysma. Okay. Why SMAS is so important? This is the layer which is lifted in the facial lift surgeries. Okay, facial lift surgeries to correct the creases. There is less than 2 centimeters painful swelling responsive to salicylates. What could be the diagnosis? Yeah, the answer is osteoid osteoma. Osteoid osteoma is a benign bone tumor that arises from the osteoblasts. It was originally thought to be a smaller version of a osteoblastoma. Osteoid osteomas tend to be less than 1.5 centimeters in size. The tumor can be in any bone in the body, but are most common in long bones, such as femur and tibia. The pain may be relieved by NSAIDs such as aspirin. Surgical ciliated cyst is often associated with surgeries of the excellent. Calvel loop procedure. Okay, surgical ciliated cyst is associated with the Calvel loop procedure. It's a locally aggressive lesion that appears as a delayed complication of surgery in the maxillary sinus region, orthodontic surgery, or Calvel loop. It may appear as a tumor with expansion of vestibular or palatine bone, cortical plates, pain in the adjacent facial area, and in some cases, fistulization. According to Food and Drug Administration, lactation categories S asterisk refers to Answer is C. Potentially significant effects on nursing infants. Medication should be given with caution. Okay. So S is safe for nursing infant. Medication usually compatible with breastfeeding. S question mark is safety in nursing infants unknown. Inadequate literature available. S asterisk is potential for significant effects on nursing infants. Medication should be given with caution. NS not safe for nursing infants, which is not a symptom of traumatic orbital syndrome. Yeah, okay. So what is orbital apex syndrome, which is a rare condition that involves severe pathologic process around the optic nerve foramen and the superior orbital fissure. The hallmark of OAS are optic neuropathy and ophthalmoplegia. There is anesthesia, external ophthalmoplegia, ptosis, fixed dilated pupil, lacrimal hyposecretion, diplopia, and decreased visual activity, but there will not be any blindness. Okay. Preoperative CT angio shows internal maxillary artery in ankylosis. Which of the following is used to cut the bone? Very good. So it is piezoelectric. Okay. Generally, we use a oscillating saw or a chisel mallet. Okay. But if there is a vessel which is very close by to the bone, then it is better to use the piezoelectric instrument. This cuts only the bone and it spares the soft tissue. Okay, this is a piezoelectric saw which cuts only the bone. It will not cut any soft tissue. Okay. So what is Janata surgical procedure? So Janata surgical procedure is microvascular decompression. Okay, what is microvascular decompression? That is used to treat the trigeminal neuralgia. What happens in trigeminal neuralgia? There is spontaneous emission of the nerve impulses from the trigeminal ganglion. Okay, that might be because of the middle cerebral artery, which has a aneurysm which pulsates onto the trigeminal nerve. So what they generally do is do a open skull surgery and place a intermittent soft tissue or a separating thin layer of tissue or pad, so that the pulsating middle cerebral artery does not affect the trigeminal nerve and the patient is cured of the trigeminal nerve neuralgia. Okay, this is Professor Janata who devised that procedure. Okay, now we'll see the odontogenic infections. Yeah, again the same question. Why we are so much concerned about the pterygomandibular space is because we give inferior block in that, and there are a lot of space infections which might occur from the the answer is lateral pterygoid. Okay. So here, as we already discussed, this is the medial pterygoid muscle, this is the ramus of the mandible, and this is the lateral pterygoid. So this is the pterygomandibular space. Medially, there is medial pterygoid, M for M. Medially, medial pterygoid. Laterally, medial surface of the ramus of the mandible. Superiorly, there is lateral pterygoid. Posteriorly, there is parotid gland, P for P. Posteriorly, parotid. Anteriorly, there is the pterygomandibular raphe. Okay, see here, this is the pterygomandibular space, and these are the other spaces. This is the superficial temporal space, this is the Mercy-Trigg space, this is the infratemporal space. Okay, see here, superiorly lateral pterygoid, laterally medial surface of ramus, medially medial pterygoid, M for M, and posteriorly parotid gland, anteriorly pterygomandibular raphe. Okay. Retropharyngeal space infection is mainly due to the spread of odontogenic infections. The infections from the tooth arises from the retropharyngeal space infections. Morbus strangulatorius, angina maligna, Garotillo are the terms used to describe. Excellent, excellent, excellent. So these are the terms used to describe the Ludwig's angina. This is given in the Arnelima Anil Malik book. Okay. So Morbus strangulatorius is because it feels like somebody is strangulating your thing. Okay. Osteoradionecrosis is due to, yeah, correct, correct. End arteritis of blood vessel. Okay. See here, this is a case of osteoradionecrosis. See here, you see necrotic bone in the mouth. Okay. There is also a pathological fracture of the bone because of the necrosis. The pathophysiology is after radiation, the bone becomes hypocellular, hypovascular, and hypoxic, resulting in the osteoradionecrosis. Okay, because of the endarteritis. Mandibular dental infection, which exits the buccal cortical plate above the muscle attachment, will cause the abscess of okay. We will see how muscle attachment helps in the spread of infection. Okay, the answer is vestibular sulcus. Okay, see here, if the muscle attachment is above the apex of the tooth, this is in case of maxilla. Okay, in the mandible it is the reverse. If the muscle attachment is above the apices of the root, muscle attachment is above, then the infection spreads intraorally into the vestibule. If the muscle attachment is below the apices of the root, then it spreads extraorally into the buccal space. See, now you come back to the question. Mandibular dental infection which exits the buccal cortical plate above the muscle, that is in the mandible. Okay. Then it will go into the intraoral because above the muscle attachment. Okay. So it will be vestibular sulcus. The facial space that is divided by the styloid process into an anterior and posterior compartment is styloid process divides, yes, correct. Lateral pharyngeal space. Okay, lateral pharyngeal space is divided by the styloid process. It has pre-styloid and post-styloid. Pre-styloid, that is medially tonsillar fossa, laterally medial pterygoid, contains fat and connective tissue and nodes. Post-styloid, that is the carotid sheath and cranial nerves 9, 10, 12. Which of the following does not suggest postoperative infection? This is a straightforward question. Yeah, pitting edema. Okay, pitting edema occurs due to the accumulation of fluid. It can be due to poor circulation, obesity, pregnancy, dehydration, low levels of protein, trauma, or injuries, or even cardiac failure. Cavernous sinus thrombosis following infection of anterior maxillary teeth most often spreads along which vessel? Okay, I can see multiple responses as D. One person has told C. C is the correct answer. Okay. We'll see how. Okay. Cavernous sinus thrombosis is the formation of blood clot within the cavernous sinus, a cavity at the base of the brain, which drains deoxygenated blood from the brain back to the heart. This is a rare disorder and can be of two types, septic and aseptic. Okay. Clinically, the clinical features are high fever, periorbital edema and chemosis, cranial nerve palsies, decreased visual activity. See here. This is the dangerous area of the face. Okay. From here, the infection travels through the facial vein, angular vein, superior ophthalmic vein into the cavernous sinus. So the answer is ophthalmic vein. Okay, not pterygoid plexus. The infection of maxillary first molar drains into any more answers? Okay, I can see multiple responses. The answer is buccal space. Okay, most commonly it drains into buccal space. After incision and drainage of an abscess, the infectious process has failed to regress in spite of the patient being on high doses of antibiotic. It would be wise to, this is all to confuse you. Okay, huge question and a huge answer. The answer is very simple. If you think logically, again, I can see multiple responses. If you think logically, it is to, yes, repeat the culture and sensitivity tests. Okay. There is already IND is done and the infectious process has failed to regress in spite of patient being on high dose of antibiotic. That means this organisms have become resistant to that particular antibiotic. The logical choice would be to repeat the culture and sensitivity test. Okay. Pericornitis is seen in relation to okay, again I can see multiple responses. It is not only restricted to the third molars. Any tooth can have pericornitis. Okay. No, you can select only one answer, not multiple answers. Okay. Around incompletely erupted crown. Dumbbell shaped swelling is characteristic of which type of odontogenic space infection? I can see again multiple answers. It is temporal space infection. Okay, because of the zygomatic arch. You see here, the temporal space infection spreads above the zygomatic arch and below the zygomatic arch. So it has a dumbbell shaped swelling. Okay. Hot potato voice is characteristically heard in hot potato voice is like somebody speaking with the hot potato in their mouth. Okay. It is lateral pharyngeal space infection. Okay. Voice is said to be thick and muffled. In oral and maxillofacial surgery, danger space is known as sometimes you have to think in terms of the examiner who has set this question. What would he be thinking when he's selected this question, and how he wants us to answer, because sometimes there will be multiple answers which are correct. You have to choose the most appropriate one. The answer is space between LR and prevertebral fascia. Okay, danger space lies between the LR and the prevertebral fascia. Danger space extends from the base of the skull to the diaphragm. It is continuous with the posterior mediastinum. Why it is called danger space? At the inferior border, it continues with the posterior mediastinum containing the vena cava, arch of aorta, thoracic duct, trachea, and esophagus. Erosion of major blood vessels, lower airway, and upper digestive tract leads to the death of patient. If there is an infection in the danger space, there might be erosion of the major blood vessels and loss of airway. Okay. Penrose drain is it is a simple rubber tube which opens at both ends like this. Okay, this is used in the drainage of abscesses or drainage of infections. What is necrotizing fasciitis? Yeah, it involves all of the above: skin, fascia, muscle, everything. See here, it is necrotizing fasciitis. It hardly responds to any of the antibiotics. It is very difficult to save the patient if the patient has a necrotizing fasciitis. Patient reported with a fluctuating swelling, which is tender. There is no history of fever, odynophagia, dyspnea, normal oral activity, and oropharynx. Blood pressure is 94/60, pulse is 95 per minute, SpO2 98%. Treatment of this patient. See, this is a huge question given to confuse you. The keyword is only this: fluctuating swelling. What is fluctuating swelling? Implies, it implies a, exactly, it implies a abscess. So you have to do IND. Okay. So we'll move on to TMJ and maxillary sinus. So repeated dislocation of the TMJ can be treated by intentional fracture of the zygomatic arch and reunion. This procedure is called, okay, everybody is read well. So this procedure is called Daughtry's procedure. Okay, so Daughtry's is fracturing of the zygomatic arch intentionally. Okay, fracture of the zygomatic arch intentionally so that this condyle does not dislocate. Okay, this is called Leclerc or Daughtry's procedure. What is Stobie's technique? I'm explaining the other options. Stobie's technique is a extraction technique used to remove multiple teeth. Okay, if you want to remove both these teeth, then you insert a straight elevator and you just rotate it like this. Okay, so both the teeth will get luxated and be removed. Okay, this is called Stobie's technique. What is Denker's procedure? It is a external radical antrostomy. The anterior bony supporting pillar as far as from the piriform aperture is removed. The access is through the antrum to the nasopharynx, posterior part of the nasal cavity, localized resection of the tumor. This is a access osteotomy to access the posterior nasopharynx. Okay. What is Weber's test? Of course, we have all studied this. Vibrating tuning fork is placed on the patient's forehead. The vibrations are transmitted by bone conduction to cochlea. The patient should state if the tone is heard in the left ear, right ear, or both ears. The sound lateralizes. That is, if the patient hear only on one side, then there might be a hearing loss or contralateral sensorineural hearing loss. Berger's flap procedure is used for it is used in oroantral communication. Okay, buccal advancement flap is known as the von Rehermann's flap or also Berger's flap. So what will you do? You put incision on the buccal sulcus, extend it, and you raise a flap, and you do something called as the periosteal scoring. This improves the elasticity of this flap to a great extent, and then you can move this to the palatal side and then suture it off. Okay, this should be watertight. This is called von Rehermann's flap or Berger's flap. So eminectomy is done for the treatment of no. It is not done for the coronoid fracture. It is done for TMJ dislocation. Same way we saw, no? This one, this is also to prevent the TMJ from dislocating. This is one type of treating it. Okay. Even if we remove the articular eminence, that is eminectomy, the dislocation improves. Okay. So eminectomy is done for the treatment of TMJ dislocation. Unilateral TMJ ankylosis is associated with the following features except no, ankylosis will always be associated with carious teeth because patient will not be able to open their mouth, they will not be able to brush and maintain their oral hygiene. This is again to do something with your muscle movement, lateral pterygoid. Yes, it is C. Okay. Sorry. It is B. Facial asymmetry with the fullness on the normal side of the mandible. Yeah, obviously, always chin deviates towards the affected side. Facial asymmetry with fullness on the affected side, not on the normal side. See here, there will be obvious facial deformity, deviation of the chin towards the affected side, inability to open the jaws, in lateral ankylosis, lower jaw shift towards the affected side, flatness or fullness on the affected side. Okay, there will be fullness on the affected side. For a 8-year-old child with TMJ ankylosis, the treatment of choice is No. You have to treat. You cannot leave ankylosis like that only. You have to treat ankylosis. The answer is gap arthroplasty with costochondral grafting. Okay. You just can't do gap arthroplasty. You have to do costochondral grafting because condyle is a growth center. If you remove the condyle, then we need something for the mandible to grow. See here, this is the CT scan showing TMJ ankylosis. Here, this is the ankylotic mass. Okay, you remove the ankylosis and you remove the ankylotic mass, and then you take a part of the rib. Okay, costochondral rib. This is a rib, and you place it here so that that acts as the growth center. Okay, it will help in the growth of the mandible. Hydrocortisone acetate is injected in a painful arthritic TMJ2. Hydrocortisone is a steroid. Yeah. It is D. Decrease the inflammatory response. Okay. Hydrocortisone is injected into the painful arthritic TMJ to decrease the inflammatory response. Arthritis is the inflammation of the TM joint. So you have to inject steroid to reduce the inflammation. Nasal antrostomy usually done through the it is inferior meatus. Okay, we need the drainage of the sinus into the nose. So the main aim of nasal antrostomy is to allow drainage from the sinus to occur into the nose. If nasal antrostomy is not done in the inferior meatus, it will result in the incomplete drainage. All of the following conditions result in oroantral fistula except Okay, Dr. Madan has given an excellent answer. It is necrotizing xylometaplasia. Okay, that does not cause oroantral fistula. Okay, oroantral fistula, the etiology is extraction of posterior teeth, facial trauma, maxillary neoplasm, osteomyelitis, syphilis, implant failures, vaginous granulomatosis, or lymphosarcoma. These are the etiological factors for the oroantral fistula. Which of the following procedures can be used to treat oroantral fistula resulting from the posterior surgery, or oroantral fistula in maxillary third molar region is best treated by? Okay, I can see multiple responses. The answer is palatal island flap. Okay. Or Aslish flap. Okay, palatal island flap based on the greater palatine artery. So you put an incision on the palate like this. Okay, and you raise the mucoperiosteal flap and you leave a pedicle attached to the greater palatine artery. Then you twist the flap and then suture it to the edges of the oroantral fistula. Okay, this will heal by secondary intention. This raw area will be healed by secondary intention. This is called the palatal flap or Ashley's flap. This is of course a straightforward question. Temporomandibular joint is a diarthroidal and ganglionoidal joint. Okay. When a patient's chin and mandible deviate to the right upon opening, which of the following is a possible cause? This is again to do with the muscle. Okay. I can see multiple responses. Okay. See, first we will decide which side. Okay, here there are two right and two left answers. Okay, so patient's chin and mandible deviate to the right upon opening. Right upon opening means right side is the affected side. Okay, mandible moves always towards the affected side. So right side is the affected side. So either it is hyperplasia or hypoplasia. Okay, so the answer is hypoplasia. There is the underdevelopment of the right condyle. If it is hyperplasia, there will be some muscle attachment and some movement. If there is a severe hypoplasia, there will be a deficiency in the muscle attachment. So it is the hypoplasia of right condyle. The joint which histologically and morphologically simulate TMJ is, I told you about the costochondral graft, no? No. We saw in the previous question, no, you have to take a costochondral graft only. Oh, sorry. It is sternoclavicular graft only. The answer is C, sternoclavicular graft. In arthroscopy for TMJ adhesion lysis, the laser used is, okay, I can see multiple responses. The answer is Hoyag laser. Okay, that is the best used for TMJ arthroscopic surgery. Why? The laser physics, tissue effects, and reports initial experience with its use in TMJ arthroscopy, because Hoyag laser can precisely and rapidly resect the cartilaginous tissues with only moderate necrosis and can be transmitted through conventional optical fibers. It has the potential of becoming a useful and adaptable system for the TMJ arthroscopic surgery. So answer is holmium, yttrium, aluminum garnet laser, Hoyag laser. Okay. Most common cause of clicking of TM joint. Sorry, that part is missing. It is most common cause of clicking of the TM joint, temporomandibular joint. Okay, I can see multiple responses. Okay, the answer is disc displacement with reduction. We will see what is with reduction and without reduction. See, in normal TM joint, this is the closed position. That is, this is the condyle and this is the articular disc. It is a biconcave disc which is present in the glenoid fossa. Okay. While opening, this disc also moves anteriorly like this. Okay, and the condyle also moves. Okay, initially there is a hinge movement. And then it glides like this. Okay, this is normal opening. But what happens in disc displacement with reduction is the articular disc is displaced. It is not in the regular position. See, this is the normal position. Here it is displaced. Okay, the disc is displaced, but with reduction, it can reduce to normal position to a slight extent. See, when the condyle is opening, the condyle can get passed through the displaced articular disc and it trying to return to its normal position. See here, this is the normal position. This is displaced, but while opening, it comes back to the normal position. So you hear a opening click when the disc is surpassed by the condyle. See, for example, if this is the disc, when the condyle surpasses this, there will be an opening click. and when it gets behind this, just it gets a closing click. Okay, so this is disk displacement with reduction. But what happens in disk displacement without reduction? The disk is fixed in a displaced position. See, normally it should be here in the glenoid fossa, but it is in the outside the glenoid fossa near the articular eminence. It is fixed there. It will not move. That is without reduction. Disc is displaced without reduction. So condyle has to force its way of opening through this. This is a very painful condition. Disc displacement without reduction is a very painful condition, and the movement is very limited. So most common cause of clicking is disc displacement with reduction. Okay, that is the most common cause. Okay, in disc displacement with reduction, when the mouth is closed, the articular disc is displaced in relation to the condyle. When the mouth is open, the disc returns to its intermediate area between the condyle and the articular tubercle. Okay, which is not a theory of TMJ ankylosis. Okay, I can see multiple responses. The answer is synovial fluid leaks and attracts calcium ions. Okay. Okay. What is the etiology of TMJ ankylosis? When there is a condyle fracture, it moves backwards and it can fuse to the zygomatic arch. In a huge ankylotic mass, it may be fused with the zygomatic arch. There is calcium around the joint. But the synovial fluid leaks and attracts calcium ions is not a theory for TMJ ankylosis. Which of the following is not done in the treatment of ankylosis? This is a very simple, straightforward question. No. Answer is not B. Yeah. See, ankylosis is something known as the condyle is fused with the glenoid fossa. Patient is not able to open the mouth. So what we do, the idea is to remove the condyle itself, condylectomy. So what you cannot do is a high condylar shave. If you shave the condyle, it will result in again multiplication of the osteoblasts and formation of new bone. So you cannot do that. Okay. Rest are all treatments of ankylosis. You can do a interpositional gap arthroplasty or ipsilateral coronoidectomy or contralateral coronoidectomy, but you cannot do a high condylar shave. Pediatric patient planned for costochondral graft for TMJ ankylosis is intubated best by yeah. C is the correct answer. Of course, tracheostomy is also an option, but here it is a pediatric patient. So you prefer awake fiber optic intubation. See, this is the awake fiber optic intubation. Okay. You attach the endotracheal tube here to the endoscope. This is the endoscope. It has a camera here and it is projected on the screen. So you insert the tube into the trachea and then you push the endotracheal tube. Okay. In a rheumatoid arthritis patient with TMJ ankylosis, progressively exhibiting anterior open bite and decreased mouth opening, the following treatment is indicated. Okay, I can see multiple responses. The answer is titanium and plastic graft of TMJ reconstruction to prevent the recurrence. Okay. Typical triad of maxillary sinusitis. Okay. Yeah. The answer is D. Nasal congestion, pathological secretion, and headache. Okay, this is the typical triad of maxillary sinusitis. During gap arthroplasty, trigeminal nerve stimulation during surgery causes. Okay, I can see multiple responses. Okay, answer is bradycardia. There is something called as the trigeminal cardiac reflex. It always results in bradycardia when trigeminal nerve is stimulated during craniofacial surgeries. We've come to the last two topics. This is the recent chapters. Okay. Technique to establish the underlying bone level. Okay. Again, I can see multiple responses. The answer is bone sounding. Okay. See, what is bone sounding? Bone sounding is the penetration of the anesthetized soft tissue by a probe in order to determine the topography of the alveolar process. Say you insert a probe to determine how thick is the gingiva. This is for all implants. Okay, placing implants. So you determine how thick is the gingiva so that you can estimate the width of the alveolar bone like this. So estimation of the thickness of the gingiva is called bone sounding to determine the topography of the alveolar process. Ridge mapping is to determine the width of the bone. Okay, so you pour a cast, you section it, and you draw a line with the bone sounding results. Okay, so this is to determine the width of the bone for the placement of implants. So that is called ridge mapping. So tapping is after the final drill, there is something called as the pre-tap. Okay, this is available in certain implants. So when you do a pre-tap, the bone grooves are formed exactly at the places where the implant grooves will come. So it is gives you excellent torque. Okay, torque is the primary stability. So pre-tapping is the placing a implant sized drill so that you can get the grooves in according to the implant grooves itself. So what is this? Of course, you would have seen in a lot of, yeah, this is a tracheostomy tube. Okay, there are two types, metal and plastic. Plastic will have a outer tube and a inner tube. This is the outer tube and this is the outer tube and this is the inner tube. Okay, the inner tube should be removed and cleaned so that there will be no blockage of secretion. This is the bulb of the tracheostomy tube and this should be filled with air so that it does not come out. This is called as an endotracheal tube, as we have already seen. This is a nasogastric or Ryle's tube. This is a feeding tube. You pass it from the nose to the stomach. Patients who are not able to swallow or eat or post-surgically, so cancer patients and all will be put in on a feeding tube through which we can feed them nutrients. Okay, liquids are fed through the nasogastric or Ryle's tube. This is the intercostal drainage tube. This is called an ICD. Okay, this is for the fluids. If the fluid is collected in pneumothorax patients, the fluid is collected in the lungs, then they put in the chest tube to drain all the fluid. Fastest acting inhalational agent is I can see multiple responses. The answer is nitrous oxide. Okay, nitrous oxide is the fastest acting inhalational agent. That was founded by a dentist. Weber Ferguson incision is for, the answer is maxilla. This is the Weber Ferguson incision, which is for the exposure of maxilla here. This is with a Lynch extension. The infraorbital region is called as a Lynch extension. Lateral trephination technique is used to correct. No. Impacted third molar. Lateral trephination technique is used in the removal of impacted third molars. See here, if the impacted third molar is too deep in the tissues, then we remove the buccal bone through a lateral trephination technique and then remove the tooth. Most commonly used cardiotoxic anti-cancer drug. Okay, I can see multiple responses. The answer is doxorubicin. That is the most cardiotoxic anti-cancer drug. Okay. Doxorubicin, sold under the trade names of adriamycin, among others, is a chemotherapy medication used to treat cancer. This includes breast cancer, bladder, Kaposi sarcoma, lymphoma, acute lymphocytic leukemia. Okay, doxorubicin. Coleman sign. Coleman sign is seen in the floor of the mouth. It is a hematoma in the floor of the mouth due to mandible fractures. Fractures. So if you see a hematoma in the floor of the mouth, 99% of the cases there will be a fracture of the mandible. So that is an important sign to detect the fracture of the mandible. Most microsurgical technique is used in correct. It is used in the removal of tissue of basal cell carcinoma. Most microsurgical technique is the affected area is numb. Dermatologist or surgeon removes the skin cancer in thin layers. Generally, what we do is remove the cancer in toto with a hemimandibulectomy for oral cancers or alveolar cancers. But this is for basal cell carcinoma of the skin. So what they do is they remove the cancer in thin layers. So each layer is inspected under microscope for cancer cell. The process is repeated under no cancer cells are seen. See here, this is a basal cell carcinoma on the forehead. So what the surgeon do is first thin layer they remove, examine under a microscope. If the cancer cells are present, then they go for a second layer, third layer, fourth layer until there are no cancer cells are present. This is a conservative treatment of surgery. You do not have to resect a whole huge region. Distraction osteogenesis was given by I can see multiple responses. Distraction osteogenesis was given by Elizaro. Okay. Elizaro gave the principle of distraction osteogenesis. Chinwala is the father of clefts in India. He is the father of cleft. He's a great cleft surgeon. Pierre Faucault is the father of modern dentistry. Angle is father of orthodontics. See, this is a intraoral multivector distractor. If you want to increase the alveolar height to place implants, you do a osteotomy, put distractor and activate it every day so that the alveolar height increases and bone is formed by secondary intention. See here, finally the ridge height was here, the middle third of the root, but after distraction it has come up to the cervical region. This is distraction osteogenesis, and this was given by Elizaro. He was an orthopedician. For the fracture of 80-year-old patient shown below in the radiography, previous treatment done was fixed with 2 fixed pins 2 months back, which failed. What is the desired treatment? No, generally you can fix pedunculous fractures with gunning splint, but not in this situation. Previous treatment is already failed. Yes, it is load bearing reconstruction plate. Okay, the mandible is very thin. Mandible is very thin and it is fractured in 2 places. So what you have to do is use a reconstruction plate, which is load bearing. Patients with positive herpes infection of trigeminal nerve faces problems in mandible protrusion. Mandible deviates to the left. Which muscle is affected? Okay, very good. Finally, I think you guys have got the concept of lateral pterygoid movement. So mandible deviates to the left. Which muscle is affected? Left side muscle is affected. Left lateral pterygoid. Excellent. Non-diabetic patient visits your dental office post LA injection to remove third molar. Patient develops double vision. What is the cause? Okay. Any other answers? Okay. Very good. So this is a small nick in the question. It is remove third molar only they have given. It is actually a maxillary third molar. Okay, they have not specified. This is a maxillary third molar. So the answer is LA is deposited in the inferior orbital fissure. Complications of PSA nerve block. Okay, so you should read the question more carefully and look for hidden words. Okay. Anesthesia of the abducent nerve while passing the inferior orbital fissure. "48-year-old patient with fractured maxillary incisor below CEJ, 5 mm gingivally. On examination, intact palatal bone from crest to apex and thin buccal bone plus normal periodontal ligament fibers. What should be the ideal treatment plan?" Okay, I'll give you a clue. This is regarding implant placement. Of course, it's a very recent technique. Excellent. Dr. Madan has got it. Okay. Socket shielding. Okay, what is socket shielding? We'll see. See if there is in 2010, Herzler et al. Introduced a new method, socket shield technique, in which partial root fragment was retained around a immediately placed implant. The aim of avoiding tissue alterations after tooth extraction. Okay, so what they do is they leave a labial part of the tooth. They divide the root into 2 halves, labial and palatal halves. They leave the labial part of the tooth intact, and they give a jumping distance 2 to 3 mm, and then they place the implant here. The tooth is left inside, in situ itself. If the buccal cortex is too thin, otherwise implant will be getting exposed labially. So to prevent that, this labial part of the root is left inside the socket itself, and again implant is placed. Surgical template provides all except, again this is for implants. Surgical template provides all except. Okay, I can see multiple responses. The answer is D. Helps to locate the alveolar crest ridge. You can't locate the alveolar crest ridge with a surgical template. Okay. This is a surgical template, surgical guide, so that you can place the implant very accurately. This is planned using a software. What is aqualizer? To be frank, I also even don't know what is aqualizer before reading this question. Okay. So there is so much advances we may not know about. So don't worry about all that. It is a water-filled channel to disocclude teeth like this. Okay, to relieve stress. To relieve stress to the TMJ. It is like a soft splint. Okay. Yeah. N-butyl cyanoacrylate is used for, the clue is there in the picture. N-butyl cyanoacrylate. Yeah, very good. Very good. Yeah. It is skin apposition. Okay. It's a skin adhesive. Don't, they will not give this picture. Only the question will be there. This is for you to understand. Okay. In plate screw system, the numbers 1.5 to 2.5, etc. corresponds to yeah. Even before reading this, I was also thinking the can see multiple responses. The answer is to screw diameter at threads. Okay. Answer is screw diameter at threads. Since the strength of the bone reduces as the size of the screw increases, it is recommended that the screw diameter should not exceed 40% of the diameter of the bone. Accordingly, there are several different sizes of cortex screw available to enable fixation of bone different diameters. Normally available are, we usually use 1.5 mm, 2 mm or 2.5 mm. Okay, that is the normal sizes that are used. This is the last topic. I hope you're not bored. Which is most commonly used tracer in PET-CT? Okay, I can see multiple responses. Why everybody is saying D? Okay, one response is C. Okay, answer is fluorodeoxyglucose. Okay, fluorodeoxyglucose is the most commonly used tracer in PET-CT. PET-CT is positron emission tomography. This is a PET scan. Okay, positron emission tomography is a fusion image in a patient of the oral squamous cell carcinoma showing metastasis to ipsilateral submandibular nodes. These are called hotspots. Okay, there is a hyperactivity of the cells. There will be hotspots. Okay, say like this hotspot in the TMJ. Stereolithographic models are used in yeah. All of the above. Okay, stereolithographic models. We will see what is that. It is used in diagnosis, treatment planning, custom-made implants, and a lot of other things also. See here, we take a CT scan of the patient and send it to a lab so that they will 3D print a model which is exactly mimics like the patient. Okay, so that we can do surgery in the model and then plan very specifically according to the patient. Say for example, we have to do augmentation or reduction, whatever it is, we can plan accordingly. This is called a stereolithographic model. This is used in orthodontic surgeries, implants, ankylosis, augmentation surgeries, lot of surgeries. Okay. What are fiducial markers? Okay, I can see multiple responses. Okay, I'll give you a clue. Which is the most recent development in all these? 4 options. Yeah. It is robotic surgery. Okay. In computer-aided surgical systems, a virtual patient is generated from the preoperative scans. Certain stable landmarks are identified on both the virtual patient and the actual patient. Okay. They need a virtual patient and the actual patient. They'll have specific points so that they can compare both the virtual patient and the actual patient. So in this technical language, these markers are known as the fiducial markers. These markers serve as a guide for tracking of the patient and surgical instruments in 3-dimensional space. See here, this is a Da Vinci system of robotic surgery. The surgeon will be sitting in the robotic console. From here, he can control all these robotic arms. Okay. Only the robo is operating, not the surgeon. Surgeon will not be anywhere near this patient. He will be sitting in the console. Okay. If you are wondering if this is available in India, yes, it is available in India, in Bangalore, Narayana Hidyalaya, and a lot of other places also, Mumbai. Okay. Which of the following has been approved as an alternative to autogenous bone graft for sinus augmentations and for localized alveolar ridge defects associated with extraction sockets? Okay, excellent. Yeah, recombinant human bone morphogenic protein 2, type 2. Okay. Yeah. Which of the following recent local anesthetics has better tissue penetration and diffusion than lignocaine? Okay, excellent. Yeah, very good. It is articaine. Articaine is a new generation of local anesthetic agent which is used, which has more penetration and diffusion than lignocaine. Okay. What is the percentage concentration of articaine with adrenaline? 2% is for lignocaine. Articaine is no. Yeah, it is 4% with 1 in 1 lakh. Okay, 4% with 1 in 1 lakh. That is the concentration of articaine. It is available in cartridges with Septodont. It is a new amino amide class of local anesthetic approved by US FDA in 2000. Of course, not very recent, 20 years old. It is available in 4% strength with 1 in 1 lakh or 1 in 2 lakh epinephrine. It has a thiopentone ring instead of a benzene ring, which makes it more lipid soluble. Okay. Yeah. What is this? This is a 3D plate. Before we were using only straight line plates like this, but now they've come up with a 3D plates. This is 3-dimensional plating system for fractures. So stabilization of 3D plates used for fracture fixation depends on, okay, not answers, all answers are all of the above. Okay, I can see multiple responses. It is because of the format of the plate which gives the stability of the fracture fragments. Okay, it is because of this design, not the thickness, not the width, nothing. Okay, 1992, Farman developed 3D plate with the quadrangular design formed by joining two mini plates with interconnecting crossbars. 3D plates whose stability, unlike traditional plates, do not depend on thickness but depends on its format. The stabilization of plates with monocortical screws form a cuboid that gives the system tridimensional stability. This stability is shown in biomechanical studies. See here, this is a 3D plates used in the fixation of condyle fractures. Okay. So this helps in stabilizing the condyle fracture. Before you used to place two 4-hole plates or 2-hole plate like this, 2 plates. But this is reduced the plates number of plates to 1. So this shows the tensile stress and force distribution by the 3D plates. These are the direction through which the forces are distributed. So there we put plates. Okay. Periotomes. Excellent, excellent. To cut the periodontal ligaments during extraction. Periodomes are used in extraction. See, these are the set of periotomes, which these are also called as luxators to remove the periodontal ligament fibers. All on 4 concept. Yeah, excellent. All on 4 was developed by Paulo Malo. Brennemark is the father of implantology, father of modern implantology. Elizarov developed the destruction osteogenesis. Paulo Malo developed all on 4. He is Dr. Paulo Malo. He developed the all on 4 concept of implants. That is, instead of placing individual implants for each teeth, we can place only 4 implants and replace all the 12 to 14 teeth in single arch. Okay, that is all teeth on 4 implants. That is called as all on 4. All on 4 treatment concept was developed by Paulo Malo with straight and angled multi-unit abutments to provide edentulous patients with an immediately loaded full arch restoration with only 4 implants. 2 placed axially, that is vertically in the anterior region, and 2 placed at an angle of 45 degrees in the posterior region. This is a implant kit which contains the torque wrench, depth, orientation, and the different drills. It also contains the hex driver. So this is the surgical guide. Okay, custom made surgical guide for all on 6. This has 6 holes, no? So this will be a all on 6 with the interactive planning software from Noble Biocare. These are the orientation pins, and these holes are used to place implants. So this is the software, Noble Guide implant software, which has a virtual 3D model generated from the scanned computer tomography data of the patient used for placing zygoma implants. Surgery was done as per the planning. Different softwares for construction of 3D models. These are the different softwares which are available. This is a zygomatic implant. See here, it extends till the zygomatic bone. Zygomatic buttress through the zygomatic bone. Other implants are placed till the maxilla. These are the newest development in the intermaxillary fixation. These are called the IMF screws. See here, place the IMF screws and you can tie this. Instead of placing a IV eyelet wiring or a Eric's arch bar, you can place these intermaxillary fixation screws and then put a IMF. This is easy. This is called as the rapid intermaxillary fixation through the elastics. This is called a bioresorbable plates. Okay. In pediatric patient, we can use a bioresorbable plates. This will resorb over a period of time. These are bioresorbable screws. This is a TMJ arthroscope. This is a TMJ arthroscope. This is called as a arthrocentesis, where you do a lavage of the TM joint. There are a lot of debris in the TM joint. You can use an arthrocentesis and do a lavage. Two needles, one placed in the upper compartment and the other in the lower compartment. And then you can flush in a lot of saline and then lavage the joint. Flush in saline through this needle and it will come out through the other needle. This is a with a monitor. This arthroscope comes with a monitor, so you can see what is going on inside the joint. Okay, this completes the chapters. Of course, it is 8 o'clock, so you guys will be bored enough, I guess. Any doubts? Okay, you want few points about electrocautery. Okay, electrocautery is used to cauterize the tissues. That is, electric current is used to coagulate the vessels. Okay, electrocautery is used to coagulate the vessels. There are two types of electrocautery, monopolar and bipolar. Monopolar, it will be like a pen, like this. Okay, it will have a cauterizing tip at the end. That will have two buttons. One is to cauterize and the other is to coagulate. Cauterize is for cutting tissues. If you cut muscle and all, you can use the monopolar. The other one is like a bipolar. That will have two tips like this. That will cauterize the bleeding vessels like this. You have to go and cauterize the bleeding vessels. Yeah, resorbable plates, they maintain the 70% of their strength at the 9 to 14 weeks, 42% bulk resorption, and by 2 to 5 years, they'll be completely resorbed. So what is all on four concept? As I already explained, when you are replacing the entire arch, see here, when you are replacing the entire arch by only four implants, that is all teeth replaced by only four implants, that is all on four. All teeth on four implants, that is called as all on four. So all on four treatment concept was developed by Paulo Malo with straight and angled multi-unit abutments. This two implants will be straight and two implants will be angulated. We also have a all on four guide to place the implants at that particular level. Okay. Okay. Any other doubts? Yeah, we would like to have some feedback. How was the class? How can we improve? Was it informative, boring, not needed? Thank you everyone. I hope you had a nice revision at the, this is almost 11th hour preparation, I guess, only 15 days to go. It was too fast in the beginning. Okay. Yeah, I understand. Because I thought we had so much to cover and so much little time. These 10 chapters, no, I used to take for a whole day. Okay, so that is what happens. Okay, thank you everyone. Thank you.